So I will have to see over there as well. Okay, I will keep it like this. This is the place where I work and teach. This is the Qasim University. One of the discipline is that. This is the special produce of the Qasim region, the Sukkari dates, which are really sweeter than the sugar. So one thing we should note that we are human beings and endoscopic sinus surgery we are doing on parallel sinuses. No two sides of a single individual has the same anatomy. What to talk of the different individuals. Every individual has a different anatomy, every sinus has a different anatomy. So we have to read each and every CT scan before embarking surgery, right? I will not go into the details of what type of scanners we are using and this and that, but we should always request for at least 1 millimeter sections. The sections are done in one model on a spiral CT scan, on axial, and they should be reformatted in sagittal and coronal plane. Both we want to see them. We should have a list in our mind that these are the structures I will identify in every CT scan. I know that this kind of disease which we are seeing, allergic fungal rhinosinusitis, we might not be able to do it. But by the time we are contemplating on those, we must have gone through the basics. Okay? Now, as already been mentioned, the normal anatomical structures we have to identify. So, like Kanasa mentioned, we should not jump. The moment we see a finding, we concentrate ourselves on that. So and there are anatomic variables. There are certain critical variants that we have to see. Is this patient is having an abnormal course of the carotid artery or the optic nerve or the Onodi cell or this? I will discuss it later on, and then we'll go into the details. Better to have a checklist in the beginning. I still have a checklist. And one thing, the films that we are getting are not outdated. We cannot read a CT scan on films. They will have to give you 100 films. So it has to be on workstation. We have to have that software. If somebody is giving you films, then please ask them to give you a CD. Now they can give you a CD, and every CD they give a small program which you can run on any computer. Okay. Always start with the first film, the gent review, or, and begin with coronal cuts, bone window setting, right? But on that program, we can always shift on to the bone window soft tissue by yourself. So we have to have all these things before we do endoscopic sinus surgery. Like mentioned, first cut, second cut, third cut, and then one thing, when we are examining the patient, we are doing surgery. We are doing right side first, left side other, right? So try to read the CT scan like that. I will see the right side, then I will see the left side, then I will see the pathology. And always look for the previous surgical defects or landmarks. Okay, now this is the first cut. Usually you get the first cut. Uh, is it working? It would not work. Okay. So, in the first cut, there is nothing big. So, this is the nasal bone, the nasal septum we go. Now, this is not the second cut, 2, 3 cuts, because there are 150, 200 cuts. I cannot go through that. One thing to note on coronal section, anterior-posterior, the first sinus comes is the frontal sinus. Right? Very clear, frontal sinus. This is the nasal bone. Infraterminate is just making its appearance. As we go a little bit posteriorly, we can see the entire frontal sinus. Right? So I will not go like down. I am just saying about the frontal sinus, then we will go down again. Now here, this is a very interesting thing which I learned very later on. We should have learned it before. This is the frontal recess. And this is the frontal sinus. Why I am saying this? This is the frontal recess and this is the frontal sinus. Is my arrow coming with? Yes. You can see there, right? Why I am saying this? Because I can see the nasofrontal beak. Nasofrontal beak is in the frontal sinus and it's very important landmark. Nasofrontal beak in CT scan, even surgery as well. Why I am saying this is the frontal recess? Because there is a gap. It is not in continuity with the perpendicular plate. There is a gap. So this is the frontal recess area. And the second cell coming is the agar nasi cell. So the first of these thymoidal cells is the agar nasi cell. Agar nasi means just nasal prominence, and when it gets aerated by the frontal sinus, it becomes an agar nasi cell. Why I am saying this is agonized cell? Because I can see the inferior turbinate, I am not seeing the middle turbinate, right? So before middle turbinate, any cell which is coming in this region is agonized cell. It is not the ethmoidal cell. There is no other cell. Other things we have to note is this: the orbit. We know the lamina papyracea coming in, the maxillary sign, the inferior and the inferior meatus. Okay, a little bit posteriorly again we are going. We make it more clear the agonized. We can see that this is the infraorbital nerve and the foramen. We can see nasal septum, maxillary sinus. Here we can very clearly see the nasolacrimal duct going down into the inferior meatus. In every CT scan, we have to identify the nasolacrimal duct, where it is, and it is very thick structure. Until unless you are too aggressive, उससे मैं हूँ तो शायद उसको हम damage करें, but unlikely to damage nasolacrimal duct in an endoscopic sinus surgery of a sinusitis or other case. Maybe eroded or something like that. So it's a very strong structure. Further posteriorly, now this is the inferior, I will go from up. Now see the skull base, which is sloping, right? As we proceed posteriorly, it will become flatter. So this is the concept that we when go inside the nose, we are going like this. Okay? Here, again the same lamina papyracea, frontal sinus. This is the middle turbinate coming in. Still it is agonized, middle coming in. Here we can see this is the in continuation with the inferior turbinate. So we have to now follow this in every cut. This is the unseated process. Once we identify unseated process in anterior cuts, now we are going to follow it posteriorly, where it is going to attach. Either to the, I will discuss it later on, very little time. Okay. Now, ethmoid bulla. Why now it is not agonized ethmoid bulla? I am skipping this right now. Middle turbinate, ethmoid bulla, uncinate process. So this is the coronal cut, is the best cut to see the ostium of the maxillary sinus, which goes like this. This is very clear maxillary sinus, it is going there. This is the uncinate, and this is going into the infundibulum. This is the middle turbinate. Middle turbinate we again follow. Where it is being attached, we follow it upwards, and it is being attached at the junction of the cribriform and the fovea. This area we call lateral lamella. We have to see its condition, whether it is thin, long, how long it is, that was mentioned, Hero's classification. I will mention in a while. Crista galli, sometimes it might also be pneumatized. Next, in maxillary sinus, we are always say about one thing, halar cell. What is this cell? This is one of the cells of the ethmoid which has pneumatized the inferior orbital floor of the orbit, right? Okay, so this halar cell you can also see in the sagittal plane as well and axial plane as well. So now this is the area of the osteometal complex that we always say. We have to classify in a sinusitis whether it is an osteometal complex disease or sphenoethmoidal recess disease. So we will see whether there is any blockage in nose. It is very clear on this side and it is obstructed on this side. Okay, incidentally there is a pneumatization of the crista galli in this as well. The orbits are okay. Okay. As we go posteriorly, we know this area just was mentioned over here. This is the skull base, right? We know that. Cribriform plate. The depth of the olfactory, Hero's is the depth of the olfactory valve. Very clear nippling effect of the anterior ethmoidal artery. If we see this, it means that this is an anterior ethmoidal artery. This anterior ethmoidal artery is very safe because it is high up. If you see a cell above this anterior ethmoidal artery, then be careful that it might be in a mesentery inside the ethmoidal roof, that is the fovea, and it might be damaged during surgery. So identify the anterior ethmoidal artery and see if there is any pneumatization above it. If there is no pneumatization, it is very safe. Okay, here we can see all the three turbinates, the inferior, the middle and the superior turbinates, and we have gone into the posterior ethmoidal cells. As we go further, okay, another view of this. So in axial view, it is not that clear, but in coronal view, it is very clear. Here you can see some pneumatization above it. It means there are chances that this might be in a mesentery. Be careful in such condition. Just the concept of lamina, which I have already said, so I will skip this. This is the lamina, which is the thinnest part, less than 0.2 millimeter thickness, at time dehiscent, and we know that force of the intramedullary artery. I am not going to go into the detail of that. Further, this is the basal lamina. The middle turbinate now going over here. Anteriorly, it is attached to the junction of the cravitiform plate. Posteriorly, it is attached to the lamina papyracea. So this is the basal lamina. Sometimes we call third lamina, and any cell posterior to that is the posterior ethmoid. Incidentally, superior turbinate is over here. So very clear orbit. We can see all these things. I will show you in another case. Another basal lamina, again axial scan, difficult to see. Coronal scan, very clearly seen, but we have to follow step by step. Now this was why we mentioned what is the Kiros classification. We know this is type 1, very small, very nicely safe. This is type 2. Why the type 3 is dangerous? Because the lamina is longer over here, more chances of damaging it when we are working in that area. Now as we go posteriorly, it is becoming flatter. The posterior skull base has become flatter. Posterior ethmoidal cells. Again, superior turbinate. In this orbit, we can easily identify the optic, the four recti. In initial, I forgot to mention you, we can even identify the superior and inferior oblique muscle. Here we can see the infraorbital fissure, inferior orbital fissure. Very important landmark, especially when we are dealing with nasopharyngeal angiofibroma. Okay. Further posterior, this is the sphenoid sinus. We have to identify the sphenoid sinus, its extensions and its relation. This is OX means orbital apex, plenum sphenoidale. In very few CT scans, we may be able to see the sphenoid sinus ostium. Even in surgery, it is not always possible to see the sphenoid sinus ostium with endoscope easily. Okay. So, further, okay, just a mention of the sphenoid sinus ostium. In coronal plane, it may be look like a ring, and in axial plane, it may look like an opening, but not easy to see in every case. Sphenoid, very important relationships of the sphenoids are there. We have to identify the clinoid process. We have to know the optic area and the carotid area. These areas might be dehiscent. And this is very important. Pterygoid plates. Can I have 1 or 2 minutes or stop over here? Whatever you say. Okay. So this is sometimes pneumatile. What is this? Root of the pterygoid. It may be pneumatile. Sphenoid may pneumatile into the greater wing. Sphenoid may pneumatile in the lesser wing. It may go into the clivus. This is the lateral extension going into this. No pneumatization over there. This we are in the nasopharynx now. Posterior coina vapor, we gone into the nasopharynx. That has already been mentioned. Any horizontal septum in a sphenoid sinus, beware of the onody cell. There is no horizontal septum in sphenoid sinus. If there is a horizontal septum, this is the onody sinus. This is the posterior most of the posterior ethmoid cells which have become pneumatized, and this area is the area of the carotid and the optic area. We have seen the plates. Okay. Onody cell we have mentioned. I would like to, in axial cuts, there are certain structures we should identify specifically. I want to give this one. You see, this axial cuts, there are so many, do not have the series right now. But this is the pterygopalatine fossa normal. We have to identify the pterygopalatine fossa in every case, especially when we are dealing with the nasopharyngeal angiofibroma. Okay. The concept of fontanelle, I also learned very late. What is a fontanelle? It is in a dry skull. There is a gap between the attachment of the inferior turbinate, there is the uncinate, there is a gap. This is called fontanelle. This is covered in life by the mucous membrane. And this we open up to make a middle androstomy. That's very clear, right? And sometimes there is an accessory opening in the posterior fontanelle. Okay. There are a lot of things about agar nasi which I cannot discuss right now, but we have already mentioned. I will skip this here. This is a very important structure. This is the most difficult area to do in endoscopic sinus surgery, frontal recess. This we can assess very nicely if we know the attachment of the uncinate. It will depend Uncinate that the frontal sinus drainage pathway is either into the infundibulum or it is into the middle meatus. Just one more comment about this. This is the concept that the larger the agar nasal cell, the smaller the frontonasal beak, the larger will be the frontal sinus ostium, and vice versa. I'm sorry, I have to go very quickly. One thing mentioning over here, this is a very nice. Why will you have sagittal? If you want to assess the frontal sinus drainage area, we call it frontal recess, frontonasal duct. It is a frontal sinus drainage area. You have to see the sagittal scan. And in sagittal scan, there are two types of cell. Anterior to the drainage area is the agar nasal. Posterior are the posterior cell, which are maybe, I will just, anteriorly there are different types of cell. I don't want to go into the details of that. These are the type 1, type 2, type 3, front intrafundibular cell, right? So you can see this in this area. This is the front intrafundibular cell. This is the agar nasal cell. The frontal sinus drainage area is likely to be compromised in this case. And similarly, I will go quickly to this. Sometimes there is a cell inside it. One thing I want to mention, frontobular cells, suprabular cells. If we have these types of cell, then the frontal sinus area. Sometimes we may say that this is the frontal sinus. This is not frontal sinus. This is the supraorbital cell, a wide extension of the ethmoid into the supraorbital region. So this is not a frontal sinus. This is a supraorbital cell. And if we see in this CT scan, we should consider that when we are doing a frontal recess area clearance, many a time I myself have gone into that area and I think this is the frontal recess area. But this is the supraorbital area, not frontal recess. Frontal recess is anterior to that. And if we try to clean the cell, considering that this is the frontal recess, we might damage the anterior artery. It is behind the anterior artery. Okay. Just wanted to make you this, and this will be my last slide. Sorry, I'm just frontal and agar nasal and frontal ethmoidal cells. So this area will be narrow. So if we find these cells, we have to remove, uncap, decap, whatever it is, this area. It has been now reported in literature, most of the frontal sinus recurrence or residual disease after endoscopic sinus surgery is because of these cells, frontobular cells and frontoethmoidal cells. Is because of these cells. We tend to just sound that area. I used to do the same previously. Just see that my probe is going into the frontal recess and I'm very happy. No, we have to remove these cells to make it a wide frontal recess. Post-operatively, there are going to be problems. Okay, thank you. I'm not going into the details of that. Thank you very much for your patient listening, and hopefully next time